Did Dave, did you guys get this cloud cover moving in up your way today too?
We did. Yeah. Not raining though, so we'll take it.
Yeah, we had it was probably mid 80s yesterday, and then this morning it all clouded over. It said maybe a sprinkle in the morning tomorrow.
Oh,
Of
really?
course, baseball can't start tomorrow, but give them a
Yeah. Yeah, I remember one of my age me, but one of my memorable baseball experiences was playing with St. Helens ash on the field um, after it blew. So, and
yeah. Hopefully they you weren't sucking too much of that in your lungs.
no, it was there. It was on there for a while, but yeah, I remember my parents years later like digging the garden, and there was like a layer of ash in the.
Yeah, stuff was heavy. I remember as a kid.
Yeah,
I
Eastern
think maybe
Washington.
they got buried out there, but I think we had a
Those,
quarter inch or something in Southwest Washington, but it was heavy. They've been like the big piles of ash that were kind of the Longview area. That's
yeah.
all been, I think it's all been used in construction, but they're putting a huge warehouse in where those piles were sitting.
Oh, really? That's
It
wild.
came out of the Cowlitz River or something.
Yeah, makes sense. Yeah, there was the that first eruption, the wind was blowing east, so like Yakima, it was like day turned to night and they had like snowdrift levels of like ash. It was crazy. I remember
Yeah,
seeing
my
pictures.
grandparents were over there. Crazy times. Hopefully, I have to do that again. So we're getting here to. I know everyone probably thinks we don't know you're here. We know you're here. We're just getting everyone in the door. So we got the June fireside chat, and we'll get this thing launched here in about 30 seconds. So get seated, get ready, and we'll have a good time as we go through this with Dave Chase. Um, I'll do my preliminary speech here before we hit start, but the Q&A function at the bottom of your screen is where I prefer that we get questions put in. So if you click on that button, type in your questions, we'll address them as we go through the presentation. Chat function is also there. If you just want to make comments, non-question related, go ahead and use it. I know it will happen because it happens every episode. Somebody's going to type a question into the chat function, and I'll think poorly of you for just a minute, but I'll still try and read it off. But with that, let's go ahead and advance the slide. Dave will put up your bio. Um, Dave, is prominently involved with Health Rosetta. That's the first time I'd met Dave, but this goes back many years now, and really have enjoyed the relationship that we built with Health Rosetta and Dave and Sean and team. And happy to have them joining us here today for our June fireside chat. And I think you're going to enjoy the conversation. So ask questions as we go through. I'll turn it over to Dave here. But been instrumentally involved in propelling what I think is the new wave of doing self-funded and designing self-funded health plans. So excited to have you on today. Let's get started, and here we go.
Right. Thanks, Heath. Yeah, no, we've really appreciated the relationship with 6 Degrees. I'm going to talk a lot about different successes we've had and how we're going to measure that today. And 6 Degrees has been a big part of that. Just to give you a little teaser of coming attractions, we're going to talk about these awards that we're going to be giving out at the end of the summer at our event called the Rosies. And 6 Degrees, last I looked, was they were a finalist in a bunch of them. So always appreciate being with people who are, walking the talk. So thanks for that. But most of what I want to do today is focus on the positive, but I think it's useful to ground us on today's reality. There's a lot on this slide, but let me just focus your eyes on this kind of item on the left. Most of us know premiums gone up a lot, deductibles have skyrocketed, but I'd really focus your eyes on the low quality of care that we get. And in the undifferentiated plans, we're not only paying sky high prices, we have really high rates of misdiagnosis on things like cancer and, musculoskeletal issues. And preventable medical mistakes are the third leading cause of death. I think there's 400,000 people die a year because of the wrong diagnosis. And, also a very large number. You see estimates between 250 and 400,000 preventable medical mistakes. We try to avoid that. The impact is devastating, right? 30 years of wage gain stolen, and overwhelming number one cause of bankruptcy is medical bill driven bankruptcy. And 70% of those people had insurance. I put it in air quotes because it doesn't sound like insurance to me. And then over to the right, this data is pretty old, but I'm quite certain it's gotten worse, where, if you steal 30 years of wage gains and healthcare premiums go up, it's not that people are canceling trips to the Bahamas. This is coming out of core stuff, housing, food, clothing, these types of things. It's pretty devastating. And so one of the things from the outset, when there's three co-founders of Health Rosetta, of which I'm one, and early on, I remember talking with Sean Shanson, who leads our technology and customer success and platform team, and we just thought it was really weird that the biggest chunk of the economy is healthcare. Health plans govern everything in healthcare. And, we can get a rating or review on everything. Like, I just took a trip and, I could rate the Uber driver, they could rate me, you could, pick up anything on your desk and get thousands of reviews on Amazon or JD Power, but nothing for health plans. And so it took us a number of years, but we basically created what we call a health plan grader, and think of it as like a second opinion that diagnoses the health plan and prescribes fixes. And it's gratifying to get this quote from a HR benefits leader that is putting this through its paces. We've got a couple thousand employers have put in them, and you get basically a diagnostic score, 0 to 100, in 8 areas of the Health Rosetta blueprint, and then an overall score. And one of the ideas here is a lot of people just think the status quo plans is as good as it gets. Most status quo plans get between a 5 and a 17. Yes, we're tough graders, but why shouldn't we be, given the lives and money on the line? If you're a 50, you're probably in the 95th, 98th percentile of all employer health plans. But people need to know where they're at in order to have the expectations reset of what actual excellence is. And what we do is we give you that, to torture that medical metaphor, we give these diagnostic score and then kind of a prescription or care plan of how to fix it. And when that is done, the results are dramatic. You see here versus, 15,000 people are spending dramatically less. There's no reason to have cost sharing in our world. Any employer, that has any common sense would much rather pay 100% of a $500 MRI than, 80% of a $5,000 MRI. And so plan design simple, make good decisions free, make bad decisions expensive. And most importantly, on the quality piece, if you chase quality, you get the cost savings for free. And, it's really gratifying to see the impact of this. Even though we're working on this really tough long-term problem, the day one of these style plans goes live, it's life-changing. People who are absolutely terrified of the healthcare system, 48 to 66% of Americans avoid care because of the cost. And really what it does is reopens the American dream. I talked about these awards. The criteria for the awards are really 3 things: the plan grade score, what did they do with the savings? If you are actually doing these things, you will get savings. These are all examples of the dividend that you get when you spend 20, 40, 50% less per capita, these are all things that employers are doing rather than absorbing premium increases or just shoving it on the backs of people least able to afford it. They're able to fund college education, home solar, daycare, whatever. That's up to the company what they do. And then the other thing that we're doing is the plan grader has 40 questions. I'm going to highlight a couple of them. And I'm going to talk about this open source a little bit later. But basically, if you look at these 40 questions, what they are is a summation or abstraction of what's in the contracts. And that was one of the insights that we had early on is all the many dysfunctions that exist in healthcare. They're all explainable. They're all in those contracts. And so what we're doing, I'm going to touch on a little bit more, is we're open sourcing. We already have done some of that. I'll touch on. A bunch more is coming this summer. What are the procurement methodologies, the best contracts, the data platform, advisor RFP. If you're an employer, one of the questions we get asked is, what's the first thing we should do, to get this? Like, got to get the right broker advisor to work with. And well, how should we select that? So we created an RFP. Heath, did you have a question? Well, we'll jump in. I'll just keep going. Okay. Feel free to jump in at any point. So we had a master's in health informatics and analytics individual that her capstone project, her name's Tracy McGinnis. She's in our industry. She did an analysis of the plan graders in our system. And I'm going to highlight two of her findings here of what were the things that really led to and were most predictive of high outcomes. One was, this is actually the law now, although there's one loophole with voluntary benefits in the law. But basically, with these above average plans, 89% of them fully disclosed direct and indirect compensation. So that was very predictive of whether you're going to have a high score. The other one I'll highlight that's certainly a driver in the score is, and this was actually the highest one, if the employer had unfettered access to claims data, which they're required under law to do that. There's the gag clause prohibition. Again, if you're going to fulfill your fiduciary duty, it's basically impossible to do that without data. And, that's shaking out, right? Some employers are having to sue the carriers for access to data, which is unfortunate, right? Of course, any company that is delivering great value that I've ever been part of any industry, including healthcare, where most of my career has been, of course, they bury you in data of all the good things that they're doing. So it speaks volumes to what's going on. But I thought that was interesting to have this, research project done that really bore that out. This, happy to share this deck with anybody. So you can see the other things, but let's just jump into a couple of these questions in the plan grader. Did the plan's benefit advisor completely disclose all direct and indirect compensation? We found up to 17 undisclosed revenue streams when we were early in the process. That's why, founding principle of Health Rosetta, which now is the law of the land, is that compensation. And then the other one was, which of the plan solution partners contractually agree to disclose all direct and indirect source of compensation? Go through this. And the way the plan grader works is you have these 40 questions, then we have 160 rules in our rules engine that we weight different answers as to what's most predictive of high performance that we put through hypothesis testing over a number of years early in the process. And if you want access to this, if you look at joining Health Rosetta's advisor program, which you have this link here, healthrosetta.org/brokers. There's information on the program, but basically there's I think it's a $99 application fee that gives you access to this 6 to 10 hour course and access to the ability to put in a plan so you can see all that. So just thought I'd put that up there if people are interested. And then on the claims data, what we ask is, do they have unrestricted access to full claims data, not just reports, no cherry picking, no just, pretty graphs and charts to sort of obfuscate what's going on. These are the questions we ask. And then we also look at what type of data analytics and reports does the plan have access to? Whoops. And so these are some of the questions. Is it analytics that were directly purchased by the plan sponsor or the advisor firm or the TPA, or is it just standard reports? And so these are things that, again, you can imagine we score differently in the plan rater based on what we've seen work the best. And what we're trying to do is what we saw early on was it was great and an initial first awesome step for individual employers, to have a high performance plan. But what we saw was that people would get to 3 or 5 and it would become death by 1,000 paper cuts. The one good thing you could say about low performing status quo plans is it's easy, right? It's easy to write a big check and have it go up. Whereas there is work to be done in these plans. And so that's been our main focus, is how do we solve the repeatability problem? How do you go from, like in this case, so we have this concept we call community-owned health plan. That's our term for something that can scale more rapidly. So Bryce Heinbaugh, he's an advisor in our program. And, 5 years ago, this stuff was new to him. He stepped in, went all in and said, this is the future. He was really burnt out on, telling his clients every year, great news, guys, you're going to pay more and get less. You do that over and over, even if you're financially successful, that's not fun. And so, he started with a single employer, 38 lives. Then it went to 1,340 lives and then 3,600 lives. Now he's over 5,000 lives in his community. Because of the great work, stuff has come in from outside where they're taking some of his services, and he's literally serving tens of thousands of lives. So that's the thing. When people go all in with the right tools that allow them to scale, they can have tremendous success. Of course, this movement's not going to grow if we're asking everybody to take a vow of poverty. That's not what we're doing. These people like Bryce are really, his problem is how to manage fast growth. And we're doing all we can to, again, solve that repeatability problem, which is, not everybody is aware that, the 3 co-founders were all tech industry folks. I started Microsoft's healthcare business many moons ago, worked in, left there 20 years ago, worked in a bunch of tech startups. Sean was a tech startup guy. Melissa worked at Dell and Trilogy. And so we have that tech background. It became obvious pretty early on that there were tools that needed to be built. We're just not really known externally in that way because we have only made our technology available so far through advisors in our program. But there's a whole process for that, including the plan grader. And one of the things that we saw, I played a driving role in 2 large-scale industry ecosystem shifts, one in healthcare and then one outside of healthcare. And the things that are the common thread is to do something like a large-scale industry shift, which is very hard. You got to have proof that your thing is better, ideally 10x better. Number 2, and this is where this comes in, you need to have standards to make it easier to do these things. And then number 3, you've got to educate the market. And so we have this kind of shipping container metaphor that we've used. And what we saw was, pre-1956, when the standardized container was created that could go from truck to train to ship to train to truck to wherever, and it could have anything from, appliances to Beanie Babies in it. And then these little things here, these are called twist locks. That's actually kind of the secret sauce there that holds these standard shipping containers. This is what it looked like before. This is kind of what it looks like if you don't standardize things. That's why we've gone to a lot of effort to do that. And as you can see, hand loading a ship before cost $5.86 a ton. Now it's only 16 cents a ton. And that's, again, a key thing we're working on. Yes, the benefits of a high performance plan are up here relative to status quo, but the effort's up here too. And so our effort is like, how do we keep the benefits up there with having the effort more in parity? And so we're not there yet, but we brought it down dramatically. That's why people like Bryce are growing so rapidly. And in order to do that, it has to be a lot bigger than Health Rosetta. That's why we're open sourcing all these insights around contracts and you know, how to evaluate TPAs and PBMs and whatnot. And if you go today to this URL on the screen, healthrosetta.org/open source, you can see a little of our rationale. I wrote a blog post of like, why would you give away your secret sauce? That seems kind of crazy. That doesn't mean there aren't other business opportunities around that. For example, as you get into some of the resources, this is one of the resources. If you go fill out the little form, it's going to send you an email. It goes off to a Google Doc. Then that in turn sends you off to other Google Docs and spreadsheets. You can see this is our open source beta for a TPA RFP. People have been treating these things like it's 100% art. It's not. It's 80-90% science, maybe 10-20% art. And so these are the critical questions to ask. Claims admin, general vendor admin. Again, you can see, a bunch of detail here. Again, if you go fill that out, this is all available for you today. And we made this freely available. And as you might imagine, as you turn these into discrete, quantitative, and things that can be scored, then you can get to the next step of having scoring a TPA submission. So you got multiple TPAs, they respond to this. And the other thing that's kind of been interesting, we didn't anticipate this, but we've also, part of the open sourcing is the model contract clauses. So we've already had some very large plan sponsors who said, wow, this is great contract language. In our RFP, yeah, we're going to ask some of those things that you saw in that previous spreadsheet, but we're going to use your model language. And your response as a TPA is to redline that contract, right? Start with something good rather than something that's not in your interest. And that's been exciting to see people take and run with that type of thing. And that's kind of the beauty of open sourcing. You don't know exactly how people are going to use that. And that was one of the more creative uses. And the other thing, when you go click on that link in the email, download click on the Google Doc, it will also show you what's coming. There are a bunch of things coming over the course of the summer. And we're going to have basically kind of a wrapper around the TPA resources. We're also delivering PBM resources. We call it field guides, where it's sort of the things that I've gone through here and more that kind of give you all of what it takes to do that really well. And then the other piece that we are open sourcing related to those, you remember this question, claims data access. Interestingly, coincidentally, we've been working with one of Heath's former colleagues who was the CTO at 6 Degrees, very familiar with claims data. And so we are basically our approach. So it's a data access platform. You'll be able to get it off of GitHub for any tech folks who might be on here, just available. It'll be compatible with like Amazon and Azure, freely available. So you can do whatever you want. We'll probably offer some managed service for people who want us to warehouse the data. But basically, Health Rosetta's model is straightforward, where it's kind of concentric circles, ripples in the pond, whatever metaphor you want to use, where there's 300 plus employers that, in tandem with Health Rosetta advisors, we're day-to-day operating in the plan. Like, our Q4 is as hellacious as anybody else who's in this space, and super busy. So that's our sandbox where we battle test these ideas for multiple years. And then we make it available. Probably 20-25% of Health Rosetta advisors ask for our one-on-one help and with their employers, their employer clients. And then we make it available. All Health Rosetta advisors, further battle testing happens, further feedback happens, and then we open source it. And that's how we think we can develop new industry standards and norms, because unfortunately, contract norms have normalized deviance. I mean, there's stuff that just is absurdly bad. And we found, as we did all these plan graders, that 95% of employers less than 5,000 employees didn't look at the contracts at all. They treat them like I treat terms of service on some consumer, website. Unfortunately, when you do that, you're giving the industry an unlimited corporate credit card to, party at the Ritz and get Dom Perignon and, hire limos and whatever else. And so that's just not sustainable. We've seen that. That's why 30 years of wage gains have been stolen. We're just trying to make it a lot easier to build a world-class plan. And I'll just say, we believe in walking the talk. In tech, there's this term, it's kind of weird, eat your own dog food. The idea of, use your own product before you put it out in the world. We've done that ourselves. So we did all we could as a very small employer. Obviously, there's some constraints when you're, say, a dozen employees. And we got our plan grade up to about 42, which for a very small plan is actually quite good. So most status quo plans are in sort of the 5 to 17 out of 100 range. And again, we did all we could. Happily, as this category has matured, we just went live on a plan this year, a new plan, that, full disclosure, we helped that organization build that plan. And it's like over a 90. Only 1% of the plan grades are over 90. 3% are over 80. And as I said, anything above 50 is pretty doggone good. You're well above the 95th percentile. But these things are accessible, down to probably 5 employees. I was actually just at NABIP. There was a package plan. They were saying they're down to 2 employees. We care deeply about smaller employers, and we're really excited about democratizing these types of things. Again, that's why we're open sourcing what we're doing. And the impact is phenomenal when people apply these plans. Health plans are no longer the number one driver of wage stagnation, debt, and bankruptcy. You look at these examples here. If you go from right to left, Rosen, hopefully most of you have heard of that story. They've been doing it 30 years in the most, the state with 40% of the most price gouging hospitals in the country, showing how you can do it very well. Incredible work. Pacific Steel and Recycling, they're close to about a decade now. And, they were spending over $8 million about a decade ago, expect to be spending 12 million by now. They've been spending like 3.5, 4 million, even while they've had some really, like 1 year was really tough in terms of claims. Good risk management addresses that. And then actually one of Bryce Heimbaugh's clients is a good example of the power of community-owned health plans. They had started with this kind of package plan that we helped Bryce build with private sector employers. And then the county did it, and then the city, and actually, no, the school district, and now the city. And Ashtabula area schools, they, this is the 8th poorest school district in Ohio. And like just about every public entity, they were very challenged budget-wise and came to Bryce, hey, can you do what you did for the county and these private sector employers? Great. So July 2020, their plan went into place. And just 10, 11 months later in May, there was a school levy. Even though it's a very challenged community, generally they would pass school levies. The voters voted it down. And normally that would have been a disaster. Close, maybe close a school, certainly cut teacher pay, benefits, extracurriculars, transportation. It would have been tough. This is not a big school district. You see less than 300 employees. Happily, even in that short amount of time, they'd saved more money than the entire school levy. Now they're sitting on like a $5 to $6 million surplus and going, oh, what do we do now? And they actually haven't even done everything. They did a lot of that outside the collective bargaining agreement. And so you can only really do it by adding new things, but it shows the impact. And one of the cool things for those of you who do some work with public sector employers, they can be difficult, they can be slow, but wow, incredible word of mouth driver. Everybody, is paying their taxes to support these organizations. And I would say most private sector employers think they're more nimble and more dollar savvy than public sector. So maybe it's even a bit of a shaming effect. And now, as I shared in that quote, Bryce is just, super busy. And because of there's that geographic density, there's real power in that. Like everybody knows word of mouth is the best marketing there is. The best content for word of mouth is success. And it's a lot easier when people are in the same community. And the fear, uncertainty, and doubt that any incumbent player uses to protect status quo just stops working when people can see it with their own eyes. And so that's one of the big reasons why we really believe in this focus in on a particular locale and, then rinse and repeat in other markets as you go in there. But just that, really works well where all of those employers there are on the same chassis, even though they're independent of each other. Same primary care, same contracts with providers, same pharmacy, same stop loss, all those things. So there's some real efficiencies. That's how you can scale these things faster rather than a bunch of, one-offs. If every employer did what these folks are doing, that would be like a $500 billion economic stimulus every year in the economy. Imagine that. I don't know if you all saw, I think it was Sunday, maybe it was Monday, the Wall Street Journal had an article that was on research that came out of Yale, Harvard, and University of Chicago, I think University of Wisconsin, Madison. And it showed that for every 1% increase in hospital prices, there was a corresponding unemployment negative impact and wage as well as federal taxes. So it's really echoed what we've been saying a long time. My last book was called Relocalizing Health. And the subtitle is The Future of Health. Healthcare is local, open, and independent. So this is the type of thing that these challenged communities, there's some hope being restored there because they're doing the right thing. And I mentioned the Rosie Awards. So one of the cool things is the people who win these awards, we can't, other than recognizing them at the event, we can't tell them exactly the good things that are going to happen, but they become the focal point. So we got a bunch of press. There's now been a few private concerts with Wycliffe Jean, I think it is, Jelly Roll, Fat Joe, Foo Fighters. We have fly-ins. This is actually Kathy McMorris Rogers and Fat Joe. So actually Pacific Steel and Recycling, I brought them in. So she's been the chair of the House Energy and Commerce Committee, which is a really critical committee for healthcare. And she has a bill. And so we were in her office And it's pretty cool. Like the employers don't have much of a voice in DC healthcare legislation, and definitely small employers have no voice. And it was really impactful. These people who've been lobbying forever, like, man, bringing in this one employer was like having 60 industry lobbyists. Um, Power of the Patients sponsored this. They drive, a lot of the legislative activity and media. Um, and we unveil this at Rosetta Fest, where we do have the best employer and union plans in America. We're really excited. We've already sold out sponsorships. We're 50% of where we were ahead of where we were last year. And we went from like in the low 200s to 700 people last year. We're really excited about how we've kind of become the connective tissue across the industry silos. So not only solutions and brokers, advisors, but we had over 100 employers and unions last year. We had over 100 clinical leaders. We had policy folks. We had employers, impact investors, all kinds of folks. So it's become a place where people are launching. There's a very well-known New York Times best-selling author, Marty McCary. He's coming out with his next book. It's going to be launched at our event. So definitely a place to be. That's where we're going to release the rest of our open source stuff. We'll also let you know that, one of the biggest names in the history of probably business is providing some of the funding to allow us to open source that work I mentioned earlier. So we're excited about that. So want to dive into the questions. There may be some that have come in from the audience, and or Heath may have some. So look forward to any questions you might have.
I don't see any in the Q&A, so go ahead and start throwing those in, guys. But lots of good stuff there, Dave. Thank you very much for going through it. One of the things that came to mind, thinking back to some of the smaller plans, is have you guys found a way of getting some of the data? A lot of the carriers aren't releasing that or making it available. And to piggyback on that, if you can or can't, then how do you start the grading system moving forward once they get into your program?
Yeah, I mean, that's been a tough thing. I mean, generally, what we try to do is we don't like to fight. We like to work with people who want to work with us. And we know if they're hiding the data, that's not a great thing. Fortunately, to get, that's been an obstacle to like getting stop loss, underwriting. Fortunately, and kind of a workaround is doing medical questionnaires. Now with some of the AI-based underwriting, we can, get some quotes, but better yet, we work with TPAs where, like, duh, share your data, right? The employer's legally bound to do that. We just want to work with good folks. And another way that people start to get access to data is moving to level funded programs. And so there's some big carrier driven level funded programs that start to get you some of that. But there's also a real explosion of level funded and package programs. We have some advisors in our community that have created level funded programs, not only for their own, some have just done it for their own clients. Others are like, hey, I'm doing it for my own clients. I'm walking the talk. But if you want to leverage off of my work, great. People like Adam Berkowitz and Josh Butler have done that. And so at that, again, if you get into the kind of the fight side of things, we do have demand letters that tend to, at the end of the day, will get our data. But that you can spin a lot of cycles, and carriers are very good at drawing things out, and like, oh yeah, we'll do that. Here's an NDA, and then they'll draw out the negotiations of the NDA for a year, or 3 months or whatever. And so it's very telling, obviously, when they're doing that. And so we just get that data. And then once you have that data, well, just knowing if you're getting data, right? That was one of the questions, then, you know, what do you do with it? Because really the key to success here, from what we've observed and then been a part of, is you have the right procurement methodology that leads to the best contracts, and then you got to validate it in the data, right? And that's whether it's through honest mistake or malfeasance, you can't assume that just because you have a good contract that people are living up to it. And that becomes how, you start to look at, oh, where are people going for their MRIs or surgeries? Oh man, those guys have terrible infection rates. That doctor is a disaster. Let's get them to quality. And when you get them to quality, get them to a second opinion, as I touched on briefly, 1 out of 5 cancers, a diagnosis is just plain wrong. Sometimes people say it's 2 out of 5 times. And then 3 out of 5 times, almost, yeah, 66% or 60% of the time, if you go to a Mayo Clinic, even if you have the right diagnosis, they will change your care plan, drawing on the best evidence. So those are the types of things that once you get the data, you get the right plan design, you can really chase the quality, and then get the savings for free.
As you guys have been reviewing and grading, I mean, what are some of the biggest pitfalls that you're seeing in plan design out there today?
Well, certainly some of the stuff we talked about in terms of lack of access to claims data, and the undisclosed revenue streams that are basically a symptom of perverse incentives. And so there's extreme restrictions on the ability to do audits, and there's all kinds of problematic terms and approaches that PBMs take. We've seen up to 30 different revenue streams that PBMs have generated for themselves when the employer thinks that they might have one or two. And so there's things like giving them the ability to define like what drugs is specialty or generic, and what's the average wholesale price, and all these things that, as you go through the plan grader questions, sort of get at both good behaviors and avoidance of bad behaviors. And another big one is anti-steering clauses. So basically, it's very common for there to be agreements between carriers and hospitals that prevent a carrier from sending people to the highest quality, or maybe put another way, avoid docs and facilities that I wouldn't send my worst enemy to. And we see that a lot, where the employers in that plan is prevented from guiding people to the highest quality care. I mean, that should be illegal as far as I'm concerned, because like anything, there's a full bell curve of doctors and facilities. There's great ones, but there's very problematic. And in a given area, it can vary. Like in Bryce's neck of the woods, there's a very well marketed giant healthcare system that's got one of their outlets is in his area. They're famous for cardiology and they're world class there. They charge like they're world class on other things, and they have some of the worst. Like you go a musculoskeletal procedure, I wouldn't send my worst enemy to some of their hospitals. The rates of infections and complications are horrific. And so that's a really big one too.
Okay. As you're going through and doing these assessments and identifying the issues that plans face, what's the average time frame to make these corrections to get a plan onto the path to excellence?
Yeah, that's a good question. I mean, it depends on where you're at. Frankly, it's harder to go from probably a 10 to a 25 than a 50 to a 65, move 15 points, because you're just making those first steps. But it's very, and like we don't have a minimum score when an advisor joins our program, they have to submit a plan. It's not about throwing people under the bus. It's like, just know where you're at. And if you have a lot of things, I would say most organizations, it's going to be a 3-year journey to get to excellence, unless they're, knocking on the door. They'll typically, if you, and this is where the consulting comes in, where, advisors will get that report. That'll be a part of their annual review process with their clients. Like, hey, here's where you're at. Here's this laundry list of things you could do. I would recommend you do these 2 or 3 things this year. You're going to need to make this decision. We may need to have this resource or whatever. And um, and let's take it step by step. We have this kind of at a big picture level, a 5-step change process. And 4 of the 5 big steps are either invisible to the member or clearly a positive. And it's when you get into some of the work you all do, that is change. It's where the biggest payoff is, but you also need to be very thoughtful about it. And so some organizations will jump into that without actually educating their employees well. And that's part of the process questions and decision making and buy-in. Is you could have world-class plan design, but if you don't have great communications and change management, it will run into problems. And so a big factor is there trust in that organization? You have very high trust companies where the relationship between the sort of front, regular workers and the execs and the organization are great. You can move faster in those settings. When it's low trust, you do some of the things that are behind the scenes. And then you do some things that are, there's a lot of shenanigans in PBM. You can do a lot of stuff even before you change where people pick up medications or the formulary. Of course, there's more opportunities if you do that. And then you can kind of build that momentum. But I'd say general, it's going to take you a few years to do it. But the benefits start compounding. And there's things like adding primary care, particularly in public sector. It's hard to do anything that's a real change. It's easier to do add-ons. And if you add on great primary care, we've seen almost overnight, you can reduce ER visits and urgent care visits 50% because they can actually get in, right? Is primary care if it takes a month to get in? It's debatable. So those types of things work well in those public sector settings. That's what Ashtabula did. And then part of that is helping guide them to the best quality facilities that also happen to cost less.
So you addressed one of the other questions I was going to ask, but it was kind of piggybacking on, anytime you have change, that can be difficult for people, even if it's a positive. And you mentioned, the work that we do, and one of the biggest single savings changes you can make is to go towards some form of a reference-based design. There's multiple ways of doing it, but that's where I think the member really sees that change.
Yeah.
I'm curious.
Have it be a win for them, right? When you waive cost sharing for somebody who's gone to a reference-based pricing and they understand what's going on, that's really powerful.
No, I agree. Especially in the education standpoint, employers sharing back, helping them see the benefit to
Yeah.
those things. In terms of member engagement and the success in these health plans, what are you guys seeing there, and what steps can be taken?
Yeah, I mean, there's a range of tools. There's some apps and things like that. And certainly one of the 8 components of our blueprint, we call it individual stewardship. You hear different terms like patient advocate, concierge navigation, whatever, like they're all kind of synonyms. I will say the ones that I've seen be most effective on that piece are when there is a care navigator, ideally a nurse, that establishes trust before the moment of truth. Once people are in the fray, something's going on, or they're in a hospital, or they've gotten a heavy duty diagnosis, you can impact things there, but it's a lot easier if you've sort of built up the layer of trust in an environment that through none of our doing, there's low trust, right? Most people, when it comes to their health benefits, it's every year I pay more and I get less. The only thing I really know is it in network or is it out network, and what's my deductible? And so having, I think of it like if you have particularly if you have a serious thing, this is like the medical equivalent of, climbing Everest. If you get a cancer diagnosis or you have some, musculoskeletal condition or heart condition, like nobody would climb Everest without a Sherpa. And having somebody there, and if they along the way, they were there at open enrollment. Hey, this nurse is there. People will tell nurses stuff they wouldn't tell their spouse. A lot of them have avoided the healthcare system. They start to have those conversations. Then it's like, oh, wow, Bob got a lab test. He paid zero. Sally got a prescription. She paid zero. Frank got an MRI, paid zero at this great facility. And each one builds up this trust. And we're seeing more and more that the all-in cost of these new type of plans for something, a medication, even a surgery, is less than the cost sharing in some of these super high deductible plans. Like it's mind-boggling, right? Like you can get all-in cost of, something might be 8,000 for some, surgery at, a free market medical association facility or, standalone, whatever, or a good, PBM on the medication side, and they're paying out of pocket, 8,000 in addition to what the employer is picking up. So those types of things like ladder up that trust, word of mouth spreads. It just makes it easier and easier for the more complicated things where the big dollars are spent.
Hmm. So we've got a few questions that have been coming in. One pretty simple, at least a simple question, maybe a expanded answer, but where do you find the most savings within these plans as you go through the grading system?
Yeah. Well, it's where the dollars are, where the dollars are spent. It's with the hospitals, avoiding hospitals that are price gougers, avoiding low quality hospitals, using independent surgery centers, and medical groups where appropriate and available. So that's huge. The Probably the easiest one to get the savings on is in the pharmacy area, because the shenanigans have been so extreme in the PBM arena that and it's nice that whether you're 10 people or 10,000 people, it's available nationwide. So it can be easier to do that than some of the other things. And it's a good way to free up some money, again, start to build that trust. And pharmacy is the part of the healthcare system the average person touches most frequently. So it is good. And like, I gave the example of Bryce earlier on. He, as a benefits advisor, called the local community-owned pharmacists. They're still out there. They've been under assault by, the PBMs and their particularly ones that have the retail, and it's really sad what's happening. And it's like, hey, I want to make you the preferred pharmacy, and develop that partnership. So it's really cool to see that kind of, pharmacists get a lot of training. They're very knowledgeable. So it's a great area to, again, build that trust.
So there's a couple of questions that came in that are somewhat related. I'm going to give my own spin to those, but um, if a lot of the merger and acquisition we're seeing with health systems, private equity, getting behind some of those and physician groups. That creates a, contrary to what they would say, creates a lack of competition out there, which can make contracting difficult. Are you guys seeing anything around that? Thoughts on that?
Yeah, I mean, that's a challenge. That Wall Street Journal article talked about how mergers and, monopolistic markets have, really created a big issue there. Um, and so the thing I would say is they are more vulnerable than many people realize. They've been some of them been kind of bullying in their activity, but there's kind of on the negative side, if you move a small part of business, that will impact them meaningfully because they're very inefficiently run organizations. But on the positive side, right, I'd much rather be more positive. Um, because these are smaller employers, it's not as high a risk for them to do something different. And if you go in, maybe you're not going to get the ultimate killer best contract of all time. But as long as you don't have anti-steerage policy, like, okay, yeah, we'll cave, maybe we'll pay 200% of Medicare rather than 500% of Medicare, even though we'd like to pay 140, 150% of Medicare. If you can still guide people to the highest value care, you can still say they're available to people. Again, with navigation, with plan design, you can still get them to the highest quality facilities. And in the case of, I'll just torture the example with Bryce, because that was like, single hospital town, price gouging hospital, very much a bully. They said, we want to go to high value. The best surgery center was 2 hours away. And if you're somebody who your life savings is less than your deductible, and you say, hey, Bob, this is the best facility in Ohio. If you go there, you're going to pay zero. They're willing to drive 2 hours. And some companies will, drive them in a limo. And in that case, they drove so much business to that surgery center called Crystal Clinic, that their county is a medical desert, less than 30% per capita physicians. Crystal Clinic said, and did, open a clinic in Ashtabula. And so those people don't even have to drive that. And so you do have to have the ability to walk, like any negotiation. If you are just, again, it wouldn't have worked particularly outside of the collective bargaining agreement to say, hey, this price gouging hospital is out of the network. Be like, oh, I thought they were the best hospital ever. But what you do is just have a way to steer away from the low quality price gouging hospitals and educate members. Again, that's where the nurses are so helpful. That's the most trusted profession in America is nurses. And hundreds of thousands of nurses have left hospitals because it's become such a toxic workplace. And so that's an opportunity for all of us to work with these amazing people who can build that trust and get people to the best quality and priced best value, basically.
Okay. We're down to our last 3 minutes. There's one question left I want to get out there, but we got to give a quick answer to it. Then I got to do my closing thoughts. But this one's around contracting as well, specifically around some of the larger systems. It's work that I know at 6 Degrees we're known for reference-based pricing, but we do a lot of contracting to support and supplement specific markets. But the question is also targeted at, is this something that Health Rosetta is doing, or something that'd be available to the Health Rosetta inside clients, or is that predominantly left to the employer and advisors to work through?
Yeah, no, if you want our help, we work with companies like 6 Degrees, right? To do that. We don't necessarily have to do that explicitly ourselves. There's people who are very experienced, like you all, to do that and that get baked into the program. And so we have a huge stake in it. And like I said, the Health Rosetta inside is those 300 plus employers that we're working directly with. So yeah, we definitely help to be a part of that, but we don't need to reinvent the wheel when there's strong organizations like 6 Degrees to do that.
Okay. Well, thank you very much. Let's get your contact information up here. I know Dave always makes himself available if you have questions or things that you'd like to talk about. Email on the screen right there. And we've got 1 minute to go.
Easy
Let's
to
hit the
remember.
last.
Dave
Easy.
at
There you
Health
go. There's
Rosetta.
me. Reach out. And coming in July, we have Dan Thompson with Thompson Wrist. That will be on July 24th at 11 o'clock Pacific time. You can find this recording and all of the others that we've done over the 3 years of Fireside Chats on our website. Go check those out. Go to the sixdegreeshealth.com/fireside chat. And I don't know, we've got several hours of phenomenal entertainment of me bounce my way through these things. So enjoy. Lots of learning opportunity. With that, you guys enjoy the last couple of days of June, and I'll see you in July. Take care. Thanks, Dave.
You bet. Thank you.